Good afternoon and thank you for attending my presentation in which we are going to talk about bone healing. Bone healing is a complex, well-coordinated process that starts autonomously when a bone fracture occurs. Due to bone tissue characteristics, successful healing is usually achieved within weeks. However, up to 10% of bone fractures result in delayed healing or non-union due to fracture severity, anatomical location, and host factors such as age, smoking, or the presence of other comorbidities. Meaning that fractures like these ones are not going to heal if they are not treated. As part of our European project, we are developing a bioengineered periosteal membrane as treatment strategy to trigger bone healing in cases of non-union occurrence. This membrane, which you can see here, is produced using metal electrogriding and is treated with plasma technology to introduce various functional groups. As a result, we have a membrane loaded with growth factors and with cells, and it can also be combined with oxygen-releasing beads. So this is what my colleagues are investigating experimentally in the lab. In my case, I am investigating the influence of the membrane in silico with the help of a 2D bioregulatory model developed in our group. The focus of the study is the healing process in a large skeletal defect. The study was divided in 3 main scenarios, representing the cases where only growth factors, only cells, and growth factors and cells were loaded onto the membrane. In scenario 1, different bar sustained release profiles of osteochondrogenic growth factors were implemented as boundary conditions. In scenario 2, skeletal progenitor cells, chondrocytes, and osteoblasts were implemented as initial conditions in the model. Here, we also explore the behavior of epoxy-resistant cells and their influence on the healing process when loaded onto the membrane. In scenario 3, we consider a combination of the previous cases. Now, before we see the membrane influence in the healing process, let me show you the control case. With no treatment applied, this is the outcome predicted by our model, a non-union. In the first row, bone formation is shown in yellow, and you can see how the bone front advances. In the second row, we see how cartilage formation progresses. In the third row, we see the formation of new blood vessels within the fracture area. Let us see now how this situation changes with the application of our membrane. In the first scenario, where only growth factors were loaded onto the membrane, we discovered that bone healing occurs when a certain threshold in the amount of growth factors is achieved. Here, the top figure shows a non-union, whereas in the bottom figure, bone healing is predicted by the model. We see that because the yellow area representing the bone front has breached with the other side of the domain. Now, if we look at the average concentration of growth factors along time, we can indeed see this threshold. Beyond it, growth factor production will ensure bone healing. This tendency was also observed when we studied different release profiles, whose results are summarized in this table. All of them follow the same trend. When the threshold was surpassed, bone healing was predicted by the model. So we see that bone healing, or bone union, is achieved when only growth factors are loaded onto the membrane. In the second scenario, where only cells were loaded onto the membrane, our model predicted a non-union case. We can see here that bone formation has stopped. The results were promising, so we added growth factors, moving to the third scenario, in which we use a combination of growth factors and cells. The results are slightly better, but the model is still predicted a non-union. As you can see, there is no breach with the other side of the domain. The question is then, what is happening here? We can see that at some point, chondrocytes are dying, but they are dying too early. You can see it well in this plot representing the average density of chondrocytes along time. As a consequence, growth factors production will also be limited, not reaching the threshold, and therefore, we end up having a non-union. What we could do here is to implant epoxy-resistant cells, which can be cultivated in the lab and survive under severe conditions. Taking as reference the last case of previous slide, but now using epoxy-resistant chondrocytes, we see that the model predicts healing. Indeed, in this case, chondrocytes are able to survive longer time, and this maintains the growth factors production. We investigated different cases of epoxy-resistant cells, and we conclude from here that when cells barely depend on oxygen, bone healing is predicted by the model. Additionally, the influence of other factors was also investigated. For example, our current model only considers the repair phase. Although the membrane is not expected to aggravate the inflammatory response, we know that there is an inflammatory response after bone fracture. What we can do is consider the time in which this inflammatory response is happening, that is, where cells are already consuming oxygen. Starting with the same reference case as before, but letting some days to account for the inflammatory response, we end up having a different initial condition for oxygen, and our model predicts union. The chondrocytes survive, and a better environment for growth factor production is ensured. So slightly different situations to start the repair phase can predict very different outcomes. We can also regulate the oxygen we have to start our repair phase with oxygen releasing beads that were mentioned at the beginning. Moreover, cells not represented in the model are still consuming oxygen. Also, if the vasculature on the bone ends or the muscles surrounding the fracture area are not damaged or sufficient, they will be a constant source of oxygen. Starting with the reference case, union is predicted when there is sufficient vasculature on the bone ends. The model also predicts healing when the musculature in the surrounding area is not damaged. When we add to this last case cells in the surrounding area consuming oxygen, we have a non-union, but it's really close to a complete healing. So we can see, all in all, that different situations to start the repair phase will again predict very different outcomes. For the case of damaged musculature, the model predicted non-union. Finally, to conclude, we have seen that bone healing is predicted with the application of the periosteal membrane, and that happens for different combinations. We have also seen that oxygen as initial condition, chondrocytes and growth factors play a key role in bone regeneration. In particular, union is predicted if chondrocytes survive to ensure growth factor production. Finally, the influence of initial conditions to start the repair phase can also alter greatly the healing outcome. In particular, the inflammatory response and the influence on the membrane geometry have not been considered currently in the model, but this is right now a work in progress and something that we are implementing in the model. In any case, we have seen the importance of computational models to identify the most impactful in vivo conditions to be tested experimentally. And that is all from my side. Thank you very much for watching my presentation.